What you don't want to do is sit on your chair all day and watch TV. You don't want to be, we said
Or play video
potatoes were
games,
good
which,
earlier,
you
but we
know,
don't want to be the couch potato.
as I drink this nice, refreshing Coca-Cola to
Please drink
increase
water.
my. Well, you know, as we are doctors, and we always say, do as we say, not do as we do. So, cheers. Welcome everyone to this episode of the JAFERD Cast. I am your host, Dr. Mark Papadakis. Nobody particularly special, just another fucking ER doctor. So this episode, I'm here with my old med school bestie, Dr. Nina Shah, who's going to talk to us about nutrition and, most importantly, Ozempic, something many of you are all either taking or at least very familiar with. So let's bring her in here. Nina, hello. How you doing?
Good. How are you, Mark? Good to see
Very,
you.
very good. You too. It's been a long time.
A little too long, I'd say.
Yeah, definitely. So Nina Shah here, she's internal medicine trained. She went to Toro College of Osteopathic Medicine, just like yours truly. We graduated the same class. And she did her residency training in Largo Medical Center in Florida, where she now still resides. How are things going down there?
Well, we're gearing up for hurricane season, so we'll see how this year treats us.
That's right.
But overall, doing really well. I guess, I'm a Florida girl, so I had to stay back in Florida.
So you're internal medicine trained, but you're in an office setting. You don't do any hospitalist or hospital work. Is that correct?
That's correct. I thought about doing a mix of both hospital and primary care outpatient, and then realized that it is just full-time. You have to be present in the office full-time. It's really hard to go back and forth because inevitably something happens and I need to be back in the office, or, something would be pulling me away and I wouldn't really be able to give my full attention to it. So I do full-time outpatient Monday through Friday and then calls.
Nice. And what your managed care? So what's managed care mean?
So it's it's a model where patients are electing to choose this insurance, where the whole primary goal is to keep the patient as healthy as possible, which I think should be the basis of everything we do as doctors.
I was going to say, it sounds like what we should be able to do in general.
All across the board. Our job is to try to take care of everything as their primary care physician, be their jack of all, expert of none is what I like to call myself, and be their urgent care, be their emergency care. If there's an issue, then I can try to get them in as soon as possible, if not the same day, then the next day. And if it's something that they're having an acute stroke or a heart attack, I'll send them your way. Sure.
Do you manage things like lacerations or it's like abscesses in your office, or is that something you still refer out?
So absolutely, it's something that is dependent on the doctor's own comfort and training. I absolutely have no problem doing certain abscesses. Of course, if there's a certain size or a certain area that's more concerning, I would send out. Absolutely, I try to do things within the scope of my practice and my training. But if there's something that's not within the scope of my practice or training, sure, I'm going to send them to the right people, because ultimately it's going to keep them more healthy than me trying to do things that I'm not capable of doing.
And it's funny because I've been seeing a lot more the last, 10, even 20 years, where primary care physicians are referring out more and more.
Yes.
I mean, we're talking when my parents were obviously younger, they came from a generation where your primary care doctor saw you in the hospital. They admitted you to the hospital, that they said, hey, you need to go to the hospital, I'll admit you. And they rounded in the hospital and then obviously saw patients during the day in their office as well. So that they really were their primary physician. Obviously, 30, 40 years later, we've gone away from that model. Is that similar? I mean, are you kind of like a hybrid of that?
So it's actually the model that I initially went into med school thinking I was going to follow my patients in the hospital, because that's what I always planned on being. But I do try to do what I can in the office. If they're having knee pain and they want an injection, I'm not going to refer them directly to ortho. I can take care of a knee injection. I can take care of some small lacerations. I can take care of certain things that can be done in the office. It doesn't have to be done just because someone has the orthopedic surgery training.
Do you find that your patients, I don't know if you know any data, but do you find that your patients go to the ER less than other models? Is there any kind of data that, shows that would be the case, or how does that?
So I don't know the exact numbers or anything. And while this model of medicine does want us to help keep the patients out of the ER, it doesn't not allow them to go.
Okay.
So they can still go to the ER. They
consequence.
don't need my permission to go to the ER. There is no consequence to them to go to the ER. It's not like the insurance company says, oh, you went to the ER, we're going to drop you. It's nothing like that. that. It doesn't reflect badly on me. However, if they go to the emergency room because they have had right leg pain that started 2 hours ago, that is something that they possibly could have been seen by me in the office. I have diagnosed DVTs. I have diagnosed ulcers. I have diagnosed cellulitis. I have treated all of those things in the office. I have started people on anticoagulation, blood thinners, and those are things that I can do. I can do stat. They can go to the radiology center. I can get the reports that same day and get people started on the proper medications if that's the case. I don't always have to send them out to the emergency room unless there's a transportation issue and I can't see the patient. A lot of patients do like the fact that this is kind of their one-stop shop. They like that they can come to me because it's easier to get in to see me than it is to get the specialist because they are even more in demand than I am.
Yeah.
It is easier. That's a lot of why people go to the emergency room, why they go to the ER, because they can't get into the specialists in time.
Yeah.
They can't get in to get their pain medications in time. Yet it's easier to get in to see me where I can at least lay eyes on them and say, hey, let's get this plan going. I'm going to start you on this. You can follow up with that doctor at that time, or I can take care of this. I can manage your blood pressure. You don't need to see the cardiologist. I can manage your COPD. You do not need to see the pulmonologist. I can take care of that. Now, if you needed a cath, I'm going to send you to the heart center. I'm not doing your cath. Things like that. That is where we try to take care of things in the office. Like if someone comes to me with an uncontrolled diabetes with an A1C of 10, I'm not throwing them to the endocrinologist. I'm going to see what their medications are. I'm going to see how I can fix that, what their insulin regimen is, what their blood sugars are at home, whatever it is. We evaluate that in office and try to manage it that way rather than throwing them to every specialist.
Now, do you take call for just your own patients? Do you cover your partner's patients? How does that tend to work?
So that's a great
question. I'm saying, especially if they're so well managed by you guys, is there a lot of communication between you guys, or is it just, no, I'm on call for my patients 24/7?
So we do have a call service. I work with my partner, and he has another office actually that he is primarily out of. And so the two offices, we basically cover each other. So we're not on call 24/7, but someone always is on call. So God forbid at 2 a.m. our patients are like, I don't know if I should be taking my blood pressure medication again or if I should be going to the emergency room because I'm having a headache and my vision's a little blurry and I think I might be having chest pain or shortness of breath, or are you having a panic attack? Whatever it may be, then someone's there to either talk them off the ledge or tell them, hey, yes, go to the emergency room.
Okay. And how does this differ from, I'm going to bring this up, not in the agenda, by the way, we're talking about something else, but how does this differ from a direct primary care model?
So the fee-for-service model where patients have the ability to go to whatever doctor they want. The other part of managed care, and I'm going to just kind of hit on this really quickly so it makes sense, is that whenever the patients want to go to a specialist, or if we feel like we need to take them to the specialist, it has to be approved by their primary care physician. That is the managed care model, which is an entirely separate topic. We could even get into that more in detail, but I won't. But they have to be approved by me. That being said, if the patient prefers a model where they can pick, I want to go to the endocrinologist, I want to go to the bone specialist because you're not trained with bones, you don't know what you're talking about. If they want to go to a model where they pick and choose the doctors that they see, then that's the fee-for-service model where they go to the doctor can take care of them, or the doctor can say, oh no, this is beyond my scope. I'm going to send you to cardiology to manage your blood pressure. I'm going to send you to pulmonology to manage your lung disease, whatever it may be, asthma, COPD. And yes, that patient could just say, hey, doc, I'd like to see the endocrinologist to follow up.
Are you owned by a hospital system, or is it just you're privately owned group?
So there's a group that I work for, and it's got multiple different offices throughout the Tri-County area. I just have one little office in that company.
You're small potatoes. Is that what you're telling me?
We're small potatoes here, but we're good. Potatoes are good.
I see a larger trend where primary care physicians are being bought up by hospital groups. And in the Northeast here, I mean, we're talking like Jefferson, Penn, all these major players are basically taking their own docs in-house, basically self-referring. And your independent docs are becoming fewer and far between. So I'm kind of curious if that's what you guys are, or if that's actually just, no, we are our own private group that has been avoiding the hospital systems.
Oh, no, we are a private group. It's a very large group, but we're not hospital owned or based or anything like that. We do have hospitalists who will go within the company who cover our patients if they go to the hospital, but we are not part of the hospital system itself, and they don't own us.
So the crux of this episode is going to be there's a lot of discussion lately about wellness, nutrition. The Department of Health and Human Services, the director, is a big wellness individual. And I made a video recently, an episode recently about him. But the main issue where we want to talk about is nutrition, namely starting on weight loss regimens and specifically Ozempic. Now, you, with this model, obviously take a lot more ownership in your patients than other models do, which is nice to hear. How comfortable and do you start patients on weight loss regimens yourself? Do you consult with a nutritionist? How does that all start to happen, if it does at all?
So we do have an obesity epidemic in this country, and obesity is not just adults who I deal with here in Florida, which is a lot of geriatric patients. It's across the board. We see it in kids now. We're seeing it in adolescents. We're seeing it more and more, especially with, even though we have all this healthy foods that people are saying are healthy, there's also a lot of overindulgence. And so part of starting people on a train of weight loss is to educate them about, what is it? Weight loss is not a quick fix. It's not a snap your fingers and it's going to happen. There's not a miracle pill or an injection that's going to work for you. A lot of patients say that they can't exercise due to X, Y, and Z, whether it's a bad back or, disability. They have, half their leg is missing for whatever veteran service that they thankfully did for us. However, it's a lot of times we see it, people just want to have that quick fix where I just want to be on the medication for a month until my daughter's wedding. I want to look good in this dress. It's not a quick fix. And that's one of the things that I always have to start with when it comes to these medications, because all these medications, no matter what medication you're on, whether it's for the good of your heart, good of your lungs, whatever it is, every single thing comes with side effects. And anyone who says otherwise is just fooling themselves.
Well, or they're actually trying to sell you something for cash that doesn't actually do anything that it advertises. So either one, really.
Either way.
Now, do you get a lot of training and education residency about nutrition, especially going into internal medicine? And I preface that by saying in emergency medicine, obviously that wasn't our focus of our training. So we didn't get nearly as much as someone as, say, a nutritionist, but we still got some of it in medical school. That was a part of our education. But do you get more? How did that look for you in training?
So in training, we didn't get like a dedicated course or rotation with a nutritionist. I didn't have that. I don't even remember if that was even an opportunity for us or an option. But of course, it was a lot of on the job, or I went to a seminar, or we, listened to a lecture. And of course, just reading on our own. I always tell my patients, listen, the key to weight loss is scientifically proven, really simple. Calories in has to be less than calories out. So you burn more calories than you take in. If you're following that, you're saying that you're eating, the healthy, low carb, low sugar, low fat, whatever it might be, whatever diet, lifestyle change, I like to recommend lifestyle changes, sustainable lifestyle changes that you have done and it's not working for you, whatever it may be. Maybe you're on chronic steroid therapy, which is making you gain the weight because you keep getting the munchies with the prednisone, because you can't be off the daily prednisone because of your PMR or your really severe asthma, whatever it may be. Those are the cases where I find myself saying, okay, I'm hearing you. I'm listening. I see your diabetes is getting worse because you're on the prednisone. I see your weight's getting worse because you're on the prednisone. But without the prednisone, your breathing's through the... Can I say shit?
Oh, yeah.
Your breathing's for shit.
Mm-hmm.
So that being said, how do you handle that? I have had patients who have had to be started on medications for that reason because they have exercise-induced asthma. Their asthma is bad for any other reason, cold-induced asthma. They cannot be without their inhalers. They cannot handle it without the prednisone because their lungs tighten up that much.
And I think that's a component of the conversation lately that's been missing, where it's not just a question of, okay, eat less and exercise and you'll be good. It's, well, that's great for your 20-some-year-old person who's in college or who's out of college and trying to lose that freshman 15. These are patients who also have chronic illnesses that may or may not have stemmed from their weight issues before, but are largely due to other factors. And so how do you tell that COPD or asthma patient, go exercise when they have the exercise-induced asthma, as you said, and they need medication for that? But by the way, their asthma medication makes their heart rate increase a little bit, it becomes a little bit uncomfortable and they stop prematurely or whatever the case may be. But, and not to mention, there are patients who don't have access to food that is necessarily in their best interest to lose weight too. It's cheaper to go to your local fast food and McDonald's, let's say, than it is to stay at home and cook.
Yeah, absolutely. That's something that we see a lot of, I think, across the country. Financial constraints that my patients will have, whether it's to get their medications, which also is another topic on hand, or that they're just not able to make the food because of some disability or other. They can't cook, they don't know how to cook. How are you supposed to prepare, a grilled chicken with steamed broccoli if you don't know the first step to take, or you can't afford the fresh groceries versus the frozen dinners that are
Right.
easy able to be popped into the microwave, which might have the fat, the sodium, and everything that you don't want to be on a diet, even if you're doing like the lean cuisine. I forget what else was out there now.
I mean, look, I'm a fan of Marie Callender's products. Their fettuccine alfredo, their roasted turkey, whatever it is. That is my midnight 1 a.m. meal when I come home after a shift. And yeah, it's loaded with sodium, right? And I literally just had a nephrologist on here not too long ago talking about blood pressure, where they say, yeah, you got to limit your daily intake of sodium to less than 350 milligrams, or your single serving, I should say, less than 350 milligrams if you want actual ideal blood pressure. And how are you supposed to do that when most of our foods, our processed foods, have added sodium, added sugar, all this kind of stuff?
And it's funny that you say that, because the processed foods are the ones that are cheap. Those are the ones that are
Yes.
affordable. They are shelf stable. They can be lasting longer. So if you have
Mm-hmm.
transportation issues, you're going to gravitate towards those things that last longer and are easy to make. And that's what we come across a lot in the primary care setting, where, oh, doc, I don't have a car. How am I supposed to get my groceries? I can't afford to have them delivered. They jack up the prices
Mm-hmm.
on the delivery
Yep.
services. There's a lot of moving parts to this. And when do we say, okay, you know what? Yes, you're ready for Ozempic? Because just like I said earlier, everything has side effects. Ozempic is not immune to
Yeah.
that
Yeah.
by any means.
Now, Ozempic is a medication that's basically was marketed initially for people with diabetes who have struggled with weight, but also, A1C issues, things like that. And it just so happened that the people taking Ozempic found weight loss to happen as a more of a side effect, I think, as opposed to a true, like, hey, take Ozempic to help lose weight. This was like, hey, take Ozempic to help your diabetes. Oh, by the way, now I'm losing weight. And I think people got wind of this, and now suddenly, over the span of, I guess, like, what, 2-3 years, it really just blew up in the medical and the influencer community now.
100%. It's actually very similar to, let's talk about sildenafil. The little blue pill that
Yes.
the gentlemen really
Yes.
like to get. That actually started out as a cardiac medication.
That's
And they
right.
noticed if they start taking more and more that they were having some sustained erections.
And we're talking now, sildenafil is a generic name for Viagra. So he's absolutely right. We all of a sudden are taking sildenafil, Viagra for hair loss, and all of a sudden the wife and the girlfriend and the mistress, who knows, is suddenly very, very happy that they're on this medication for hair loss, of all things. And now
They're
we all of a
getting
sudden have
some better side effects.
they're getting
of
some
that
better side
medication.
effects.
So they take more and more, and then they feel like, oh, okay, that's happening more. The similar concept to Ozempic. Ozempic was originally, directed to have help with the diabetes. And of course, a lot of the diabetic patients are overweight. They are carrying the extra weight, which is why they ended up in the diabetic range, or maybe it was a familial component to it. Whatever it may be, we have noticed that if you lose weight, your diabetes can get better. You're off a lot of the
Yes.
medications. Maybe you get off the insulin. Hey, doc, I'd much rather take a once weekly injection than having to stick myself with insulin 3 or 4 times a day, whatever the regimen may be. I'd rather take that than have to take metformin and glipizide and pioglitazone, whatever. They think it's the catch-all, one-all. However, because of all this weight loss explosion that happened with it, people, especially like the celebrities, people would lose 40 pounds in a very short amount of time. And everyone's like, I want to look like that now. Oh, yeah, they were really overweight. And now they're, skinny minis, whatever you want to call them. And now it just skyrocketed to the point where the people who actually were supposed to get the Ozempic are not able to get the Ozempic. And it is really expensive. So it makes it another difficulty to get it for patients who actually need that.
There's been discussion lately about insurance plans for this year, even in my hospital system, where they're not going to cover Ozempic, or they're not going to cover it completely. So now it's becoming more expensive to use it, assuming you're using it for pure weight loss and not associated with diabetes. And to be clear, we're talking about diabetes type 2, your insulin resistance. Diabetes type 1s,
You have to
you need the insulin no matter what. Sorry, guys.
To be fair, the majority of type 1 diabetics are skinnier, so they don't really need the weight loss. Generally, don't find my type 1 diabetics running towards Ozempic. But I do have lots of type 2 diabetics, and I have a lot of patients who are non-diabetics who want Ozempic. Mark, you kind of asked me about it earlier in this conversation. What do we do for the patients who can't handle vigorous exercise? But I'm going to define that again. Vigorous exercise is not the same for me as it would be for a man or for a bodybuilder or for a long triathlete or somebody. Vigorous exercise for them might be running 50 miles. You asked me to run 50 miles, I'm going to be on the floor. But vigorous exercise for me might be like a spin class or something. I could go ride a bike for 45 minutes and I'm like, hey, I feel really good. I'm getting my heart pumping. But vigorous exercise is dependent on the patient's or the person's already their physical capabilities. If your heart rate can get up to that 150 with the exercise, you're probably in that moderate vigorous exercise range already. What works to get me up there is not going to be the same thing that works for a triathlete. They're going to run a lot longer for that.
Yeah, and we also, the old adage, and we talked about in another episode, is 10,000 steps a day, right? But, 10,000 steps a day sounds great. If that's all I need, it's not. It depends upon your body type. And if you are severely overweight with chronic disease and you can only manage 5,000 steps a day, great. You're still putting some kind of stress and you're burning something in your body to help get that working again. For somebody like me, I probably need more than 10,000 steps a day to get my heart rate up because it's my metabolism. Maybe I need 20,000 steps or 10,000 steps plus, like you said, a spin class if I'm going to really want to do exercise.
It's about I think I heard it in one of your previous episodes too. It's about the moderate exercise. You want to average about 150 minutes per week, which can be done in 5 30-minute sessions, depending on what you like, or 3 50-minute sessions, or however you want to divvy it up. I have patients who do 20 minutes a day. They'll do 10 minutes in the morning and 10 minutes in the evening, and they do it every single day. That's about 140 minutes in a week. That's almost there. So it really depends on how you want to do it. But when my patients say that they can't do it for very long, I say break it up. Do 5 minutes before breakfast, do 5 minutes before lunch, do 5 minutes before dinner, and then go for an evening walk around the block with your dog.
So is there a stepwise program that you have with your patients? Do you recognize immediately, you're somebody that's going to benefit from being started on Ozempic immediately? Or do you try to say, let's try a regimen, let's give it a week, 4 weeks, 2 months, whatever the case is?
So I'm going to say that there's not really a set program that my patients have to go through. Everything is really case by case, depending on what the patient is going through, depending on what they've tried, depending on how long they've been struggling with this. And of course, depending on their comorbidities to see if they even qualify for Ozempic. Is the risk worth it?
So you talk about comorbidities and risk. That's something that, there's also discussion about side effects. So what comorbidities do you look for specifically when looking for Ozempic, to starting on Ozempic?
So obviously you want to see, hey, do they have diabetes? Is this one person who actually I would have thought about starting someone on Ozempic? If they don't have diabetes, it's really hard pressed for me to say, yes, I'm going to start you on Ozempic. You have to have a significant amount of heart disease, lung issues that would be worsened by your excess BMI or your elevated BMI, body mass index, however you want to say it, to be
it's interesting.
Go ahead. To be able to say, yes, I'm going to start you on it. However, the side effects are such, they're great. I've heard podcasts of people who did great with Ozempic and they lost the weight. And I've also heard the opposite, where you don't hear these very often, where people were on the Ozempic, but they didn't lose the weight. In fact, they couldn't handle the almost stunted GI system that they had. The way that Ozempic decreases your appetite is by slowing down your gut mobility and how food actually is digested. Your entire digestive system is slowed down. But by doing that, you decrease one's appetite, but you can also make it extremely painful and difficult for when you don't get the nutrition you need on a daily basis because you're just not hungry because nothing is moving. You're then now malnourished. You have vitamin deficiencies. You're not getting the nutrients you need. Your protein starts to go down and you're going to lose muscle mass. You may not lose weight. You're going to lose muscle mass. You'll replace it with fat. You're not going to have the energy to work out. How are you supposed to build that proper protein in the muscle in order to get that healthy weight that you want? You don't want to just lose weight. You want to lose the fat, not the muscle, because otherwise, how are you supposed to do your daily activities?
Yeah, and that's a very good point. There's the recommendation is interesting. I had to look this up myself. The protein recommendation for men to not just build, but maintain your current body mass, I have it up here, 0.36 to 0.45 grams per pound of body weight. So if you're someone who, let's say, for argument's sake, weighs 200 pounds, you need about 100 grams-ish of protein per day to maintain your current muscle. I'm not talking about your,
building,
or whatever, maintaining. Just the actual muscle that you have. And if you don't get that, now suddenly you're dropping. And for women, it is a little bit less. So yeah, for women, it's a little bit less. We're saying 1.2 to 2.2 grams per kilogram of body weight. So obviously the conversion factor is a little bit different,
Say
but
it's
it's still
100
the same
kilos.
idea.
We could
Yeah.
make
You
it
know,
easy.
so now you have somebody with, like you said, a gut that's completely slowed down. They're not able to absorb any, not even just absorb the nutrients, get the nutrients where they need to go because they're vomiting. I've seen more and more cases of people coming to the ER lately with nausea and vomiting, stomach pains, things of that sort, diarrhea. And we're now asking their history of what medication you're taking. And it's starting to come in with more and more as saying, oh, I'm on Ozempic, and I started Ozempic a week ago, 2 weeks ago, a month ago, and now all of a sudden their body's starting to have this reaction to it.
Yeah, and
And
people will say that they're on Ozempic for some time and not realize that some people are being titrated to their doses and that they went to a higher dose and all of a sudden they're having difficulty with it. And they're like, no, that doesn't make sense. I've tolerated this already. They don't want to blame the Ozempic.
well, because it's for them so far, it's been a miracle drug. This is the thing that has helped me lose weight finally. So therefore, if I go off of this, I'm going to do, with a whole V-shaped recovery in terms of weight gain. And they don't want that. And I completely understand that. And you mentioned titration. Do you titrate the medication up, or do you have like a fixed dose that you start people on? How does dosing work for you?
So it's not, again, there's nothing fixed. I would start them on the lowest once a week and probably see them again in 1, 2, 3 months, depending on both their schedule and how much we're trying to see them lose prior to that. Now, after 3 or 4, 6 months, if I'm not seeing any changes and we've titrated them, I'm going to start talking about taking them off of it because they're obviously not getting that benefit. And there's no point in taking a medication that'll stunt their GI system that way. However, if I start them on it, we're getting a little bit, we're not quite there yet. I might, after 3 months or a month or two, increase it. I might say, hey, take double the dose. We're going to change your dose to double it, and titrate it up to the point where they can potentially get that without having the side effects. I do it really slowly because a lot of my patients have other issues going on that already cause gut issues, that already cause nausea, vomiting, and I have to make sure it's not the Ozempic that's doing that. Because, again, these side effects can be really confounding and confusing because they're really nonspecific.
Have you had guidance from the drug manufacturer about how often to follow up or how much you titrate here and there?
So no, not directly, just based on reading up on the medications and stuff. Titrating up, I haven't really had to titrate too high. I've generally not had to do that more than once or twice, and then we kind of find a steady state. A lot of patients get to their goal weight and then they're staying there. But again, if they've gotten to their goal weight and we take them off automatically or something like that, they're going to regain all that weight right back. Some people are like, I'm just on this for life and I'm accepting it. And some people are like, I only want to be on it and then try to maintain. Now that I have lost the 50 pounds, maybe I can get back into the gym. Maybe I can go out for a run again. Maybe I have the ability now. My athletic ability will be even better. And I can do it on my own now and then maintain it on my own. Now there's a catch-22 about that. We see if it works.
So that's interesting because what I'm hearing is basically there's two types of patients. Your one patient, you're saying, okay, you're going to be on Ozempic because you are functionally and physically unable to perform the workouts needed and the exercise needed to lose weight. So therefore, let's kickstart you so that you can be at a level where you can start to actually exercise and work out, and then eventually you won't need the medication anymore, versus the people who, if you drop it or take it away, everything's going to come right back again. But is that a function of their socioeconomic status? Can they not afford healthier food where they're eating more and more processed, dense, sodium dense foods? Or is it an issue of self-control?
So it's probably a combo for my population of patients. A lot of them do have the fixed income. They're retired. They're working on, whatever retirement fund they have had left, or somebody else's retirement fund, their late husband or whatever it might be. So for that side, it's a 90, I don't want to say 90%, but it's a very high amount of patients who have that fixed income. So obviously finances are always going to be a little bit on the tight side. Eating healthy, while some of them get assistance from the insurance company a couple times a month or a week, they get a little extra to buy those healthier foods. It's not always going to be the case. They're not always going to be able to stick with that. So eating healthy is difficult just purely because healthier foods cost more.
And that was going to be part of my other question too, which is, do they get assistance to purchase, food? Like right now, at least as we're talking, there's budgetary proposals going through the federal government that talk about reducing SNAP benefits, reducing a lot of these benefits for, the working poor and lower income families, where they relied on them, ideally relied on them to purchase healthier options, but obviously that might be rolled back a little bit. But insurance potentially can help offset some of that cost too, it sounds like.
So yeah, of course it depends on the insurance company and their policies, and I'm not really privy to each and every single fine line, but there are certain patients with certain comorbidities in the insurance companies that I take that do get a little bit of benefit and a little bit of assistance from them. I don't remember if it's a weekly or a monthly thing, to help them afford those healthier groceries, and they are directed towards only those healthier groceries. I think they have like they can't just go buy some ice cream with it or something.
So that was going to be my question as well. Is there limits to what they can spend this on? And it sounds like there are. Ideally, if you're going to say here's money for a healthy food, they can't just spend it on gummy worms or something like that, or a Snickers bar. Like, no, this is designed to help you buy that head of lettuce or these herbs and that breast of chicken. Now, I want to circle back to something because we talk about follow-up. You said, you follow up in 1 to 3 months, you're titrating things. You work, as we talked about earlier, a managed care model. So you have the resources and the capacity to actively manage and follow up on these patients. But I see patients when they come into me, they're not able to see their primary care doctor in like 6 months or something. It's okay, my doctor put me on this and I'll see you in 6 months or 8 months or whatever the case is. Is this a medication that people should be actively followed up on in the short term, or is it just, how does that work here?
So I personally don't think it should be 6 months, 12 months. You start on any patient I start a new medication on, I usually do not see them. I don't put them out for further than 3 months. It's usually going to be at the furthest a 3-month visit, because
for any medication, not just Ozempic. You're saying for any medication.
For any medication, not just Ozempic, because things can happen and sometimes the patients don't know how to convey that. It's my job as their primary care physician to figure out how things are doing. Sometimes they don't know how to convey, hey, I'm getting dizzy. I don't realize that my losartan might be too high of a dose and my blood pressure is tanking.
Yes, and that's how you wind up in the ER, because suddenly you're, 8 o'clock at night, getting up from your chair, you feel dizzy and
you fall
like, why am I feeling dizzy? Yeah, you fall on your head. And exactly. Yeah. And I say, well, your blood pressure was 80 over 50. Here's some fluids. Go home, follow up with your doctor. And then it's like, well, I can't. I have another appointment scheduled in 4 months. So now I'm left with the task of, do I reduce somebody's blood pressure medication? Was this a one-off occurrence too? And that's part of the issue that, emergency physician has, which is, okay, your blood pressure was really high for this visit or really low for this visit. It's better now, but I don't know if it was the medication that was maybe doing it. I don't know if there's something, your body is just changing because you haven't seen your doctor in a year and now this medication's working too well on you. Who knows?
I'm glad that you said that. In our model, whenever a patient goes to the hospital, whether it's the ER or they were actually admitted, we have a time that's set by the insurance companies that we need to follow up with them in office. So for ER visits, we like to see them within, let's say 7 days. For hospitals, we have a little bit longer to see them because they might be a little bit more complicated, might need to get more records from the hospital, which is an entirely other issue.
Yeah, that is. That's a pain in the ass.
I had a patient go to the emergency room today. I'm getting her in my office tomorrow.
Now,
I
is
have
that
built-in space in my schedule, though.
Okay? That was my next question.
Sure.
Is that built in? Good.
I try to build in, maybe 1 or 2, some days 3 spaces where I can get those same days and where I can get the person who says that they can't breathe and they think they might have a COPD exacerbation. Well, let me listen to your lungs. If you're wheezing, I'm going to get you on a breathing treatment here in the office. I'll give you the steroids in the office. I'll get you on your prednisone. I'll get you your antibiotics if you need it, and then I'll get you on your way and follow up in 3 or 4 days.
Does your office have ancillary staff like respiratory or diet, or is somebody aside from just you guys, obviously, is there staff that you can call on a moment's notice and have the patient, hook the patient up to? Like, how does that all work?
So no, I don't have a respiratory therapist, like a dedicated respiratory therapist or a nutritionist or anything like that. But my nurses are trained to be able to give them the albuterol, the Duaneb treatment. They're trained to be able to do basic injections IM. If it's something a little bit more difficult and if we can't do it in the office, then I try to get them to the resources that we have within the company.
That's nice.
We have infusion centers that sometimes I can give people fluids in. I've done that before. That was a little bit more difficult, but we did it.
Yeah, it's impressive. The reason why I asked is because when I was a student, now I rotated with a pulmonary critical care physician who also had a primary care physician. So he would see patients in the hospital. Usually in the mornings he would round, but then he also took care of many of those same patients after the fact. But he had a dedicated respiratory therapist who would be able to hook somebody up to a nebulizer, give somebody prednisone, things like that in real time, which did save patients a trip to the ER in many ways. In your group, do you find that you are more liberal in giving Ozempic and starting patients on Ozempic, or a little bit more conservative when starting them on Ozempic? How do you kind of fall in the gradient, if you would say?
That's actually a really easy question for me. I'm definitely more on the conservative side of things. I do not like starting people on Ozempic if I can help it. If I know that they have not been getting up, they have not been exercising, they're not eating right, they're not trying to do anything. I mean, listen, I know that a lot of these patients have mobility issues, but they also have walkers, they have canes, they're encouraged to walk. You don't want them to lose. You don't use it, you're going to lose it. So if I tell them, hey, yeah, you can have the electric scooter, you don't need to walk, they're never going to get up again. They're going to be on their ass. I've seen it with 50-year-olds. I've seen it with 60-year-olds. I've seen it with the 70-year-olds. Now we get to 80s and 90s, we're talking something different. But if you don't use it, you'll lose it. So if you're not gonna walk with the help with the walker, then why are we talking Ozempic? I'm not gonna give someone who's sitting on their butt all day Ozempic. I'm sorry.
There's a mindset that I've talked to several people about this, and there's a mindset that Ozempic is a shortcut. And for some people, it's the idea of you shouldn't need a shortcut. You should try X, Y, and Z first. Other people say, well, listen, we use cars to drive around our neighborhoods, which is technically a shortcut. So why not use Ozempic as a shortcut to weight loss? And I think what's missing in this conversation is what we touched about, which is it's this: how long do you keep patients on Ozempic? And for what purpose? Because if they don't learn healthy habits, if they can't access the right foods, if they cannot exercise, then ideally you want them off medication. The whole point of a lifestyle change is to not rely on medication. And yet Ozempic is one of those medications where it sounds like you may have to be on for quite a long time, if not for life, to maintain what benefit you have from it.
100%. Here's the thing about Ozempic is that even though it's marketed as a weight loss drug, it's a weight loss drug that's marketed to be used in conjunction with healthy eating and exercise. So if you're not doing that, I don't really see, maybe miraculously or luckily you'll have very, very little intake. So yeah, obviously calories in is less than calories out. So that might be the effect you get. But if you're not exercising, you're not following a healthy diet, you're not going to get the maximum benefits from the Ozempic based on the studies that we have. I have seen people say, oh, I'm on Ozempic. They haven't lost a pound. Oh yeah, we celebrated, went and had, cheeseburger and some French fries, and then we treated ourselves with a little chocolate cake. Well, you know what? That sounds delicious, but it's not working with your diet.
There is a discussion on one of my previous episodes about discipline. And it was the idea that if you have the discipline, you won't need the medication. But if you don't have the discipline, now you need the medication. And ideally, in an ideal world, the medication is there to help support you to get to where you need to be mentally and physically, where that you no longer need it. But obviously
100%.
That's not the case.
People do look for, the easy way. Oh, this is a surefire way. I'm going to do it. I'm going to look like, the next Rebel Wilson, or I'm going to be that person. Sorry. I'm going to be able to do that in, 3 months time, and everyone's going to look at me like I'm a brand new person. They're not going to know who I am. They're going to walk by me and not realize that I'm their daughter, whatever it may be. But again, it's all about the discipline. You have to combo it with the diet and exercise. But again, nothing is going to be quick. Nothing is going to be in 3 months. The studies have proven that this is over like a 12-month time frame, which you could lose 1 to 2 pounds a month easily with the proper diet and exercise. And it's a very slow weight loss, but it's a healthy weight loss because you're doing it with the proper way. Calories in is less than calories out.
And we also have to add to that, it's also the type of calories you're eating. If you're going to say, well, I'm eating, only 1,000 calories a day. Yes, but if you're getting most of your calories from heavily processed foods, that's different than eating 1,000 calories of, chicken breasts and pastas and, lean meats and
Sure,
vegetables.
sure.
You're
Where's
going
your
to
omega-3s with the fish? Where's their lean meats and proteins? Where are your vegetables? Where is your fiber? That's all going to keep things going, especially on Ozempic. You definitely want to make sure you're taking some fiber because, again, some of
yes.
the biggest side effects we see on Ozempic, I talked about it earlier, the slow digestive system. People get small bowel obstructions, which can kill you. People get pancreatitis, which can kill you. All of these things are things that we have to monitor. How's your stomach doing? Are you having nausea, vomiting? Are you having normal bowel movements? Things like that. When I follow up with them in the office, those are some of the questions I'm going to ask them because those are some of the side effects that we see in
As
on Ozempic.
And it's important also for those who are on Ozempic to understand that if they're having persistent nausea and vomiting, severe abdominal pain, it very well could be an infection. It could be appendicitis. Sure. But if you come to the ER and I diagnose you with basically nothing, hey, we found nothing in our workup. Your pancreas is normal. There's no obstruction. This is the medication that's doing this to you. And I think there needs to be greater understanding that this is the risk that you signed up for when you're on this type of medication. It's not easy street.
No.
There's marketing, there's social media influencers out there that will tell you it is, but it's actually not.
But that's what they think is. So influencers will create, that's their job, is to create an enticing environment, whatever it is they're influencing you on, whether it's makeup or cooking or a book or medication or a lifestyle. Oh, you should try this meal. This recipe is really good. Maybe it is. Maybe they're going to spit it out as soon as the camera stops. We don't know what happens on the back end. We don't see the behind the scenes all the time. But the same thing is like I mentioned I listened to a podcast, this is years ago at this point, where the patient had been on Ozempic. They lost nothing. They were malnourished. They were the same exact weight, and they had so much fatigue because they just didn't have the energy or strength to do anything.
Yeah, it turns out their hemoglobin was probably low because they weren't getting the right B vitamins and
and
all this
anemia
and
is
that.
a thing. Anemia is a thing with Ozempic. The nausea, the vomiting, the diarrhea, that all causes dehydration. There goes your kidneys. There go your kidneys. When you have gallstones, and then now you have to have a surgery to take that out. Now, after a surgery, you want to be on Ozempic, which I don't think is a good idea because that causes more issues with your GI system.
And obviously, there's, I don't want to end the episode on all doom and gloom. There is a population out there that does benefit and will benefit from Ozempic, but
Absolutely.
I think the take-home message to our patients is it's not a miracle cure. It's something that has to be used in conjunction and that has to be heavily monitored too. You can't just take the shot. You can't just take the shot, walk away from your doctor and say, okay, we'll see you in 6 months or see you in a year. No. This is something that we have to keep very, very close watch on you on. And you need to be aware that if you start developing side effects, this isn't temporary. These are side effects that are going to persist until either you change the amount that you're taking or go off it entirely.
Sure. And this medication, it's a once a week injection because it lasts a long time. So these medications, the side effects are something that's going to be present for a few more days to the full week. Now, if you did have significant side effects, I'll talk to you. We can decrease the dose. We can see how you did. You did okay on this dose. You want to go back on that dose and see how you do and then see how the weight loss goes? Or do we take you off of it? In which case, I can either titrate you off because we want to make sure that your appetite doesn't come raging back and then you regain all this weight, or we can take you off because the side effects are too great and you just can't tolerate it. And we can do both sides of it. We can titrate you off, or we can just take you off directly.
Yeah,
There's
it's
no
not all or
harm.
nothing. Yeah, it's not all or nothing, which is
Yes.
good to hear too.
And it's what is take home for Ozempic is it's really case by case. I think some doctors are definitely more liberal with Ozempic. I can go either way. I'm definitely more on the conservative side. But yeah, I have a patient. She's on therapy, chronic prednisone therapy. It's definitely making it hard for her to eat right. It's definitely making her gain weight. Her sugars did go up with it. The Ozempic was actually perfect for her. I saw everything go down. Her weight went down. Her sugars went down. Her A1C went down to 5.4. So
basically what you're saying is talk to your doctor first.
Please talk to your doctor. Actually, I do want to touch on something. I have had patients who've come to me and said, oh, I got the Ozempic from this online company. There are a lot of these freestanding companies I'm hearing about so much. Now, I don't know their names, all of them or anything like that. I don't know how many there are, but I have actually had to take patients off of them because I almost had a patient with an obstruction who was getting it from there. But there's no monitoring. There's no blood work. There's no follow-up. Okay, you're doing well on this. Let's go up on the dose. You're doing well on this. Let's go up on the dose. Hey, you haven't picked up your prescription in 30 days. Do you want more? I don't get it, but that's really dangerous to me. Like, if you truly want to be on Ozempic because you feel like you have no other option, please talk to your doctor, the ones who are following up with you on a regular basis. Now, Yes, there are some people who once every 6 months is the visit that they need. But if they're on Ozempic and we're starting them on one and they're not stable and steady on it yet, I'm going to bring you in a little bit sooner. But that's my model. That's what I like to do. I like to see my patients in the office because it keeps them out of the hospital. I like to say, hey, you know what? We're going to see you back in 3 months. I'm going to have you go up to my staff and they're going to make sure you get your card and your lab appointment. If you have any questions, please give us a call. We do have someone on call if you don't get us during business hours.
And I think that's your mention about finding medication, getting medication from a non-provider or an off-site service or whatever the case is. That's not new either. I mean, I see ads for Hims and Hers and the availability of these medications that honestly need to be evaluated before they're started on, because
it goes back to, just like I said with the Viagra. People were getting Viagra off these independent pharmacies or whatever they might be just because they wanted to have, an active sex life. And that's okay. We get that people want to have an active sex life. However, they also didn't inform the people that they were on a nitroglycerin, which now they're passed out in your emergency room again.
And I give them nitro for whatever may be happening, didn't know they were on this medication, and suddenly now they pass out in front of me, and I'm like wondering, what the heck did I do here? Turns out it was a medication overdose. I just didn't realize it. Well, Nina, thank you very much for coming on. This was great. I loved it. I think we touched on Ozempic, obviously, risk, benefit, side effect profile, but also we need to reinforce with all of our patients. And this isn't just you. People think this is a primary care problem, but it's not. It's every single specialty has to, and to some extent does, reinforce the concept of healthy eating, healthy lifestyle management, and really discuss it with every single patient that comes their way. Ortho can have a discussion, the same with emergency, the same with primary, and the same with pulmonary too. It's kind of everybody's best interest for these patients to have these types of discussions and really take a look at their lifestyle and see what can be improved.
Yeah, it's 100% a multidisciplinary fact there, because lowering your weight can improve your heart disease. It can improve your diabetes. That's the endocrine side of things. It can improve your lung function. It can improve your joint pain because your body's not carrying as much anymore. Mm-hmm. So there's so many things that, yes, being obese or being overweight can worsen. Something that all those specialists should be talking about, should be mentioning to their patients. Yeah, it's probably time to lose a little bit of weight. These injections are only going to take you so far.
Ladies and gentlemen, Dr. Nina Shah, thank you again for coming on. We'll have you back on here at some point in the future, I'm sure. We'll talk about some other crazy stuff happening in world medicine. I'd love to. All right, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Nina Shah for coming on here talking about Ozempic, weight loss, nutrition plans, and a bonus managed care, which is a model not many of us have actually realized is out there. Tune in again. We're going to talk more about other aspects of healthcare, including, hopefully soon, first trimester vaginal bleeding. One of my former colleagues is going to be coming on talking about bleeding in the first trimester. She's OBGYN. And eventually we're going to have content on apraxia of speech with a speech therapist, and maybe revisit the idea of diet and nutrition from a dietitian. We'll see. But if you're interested in coming on to talk about the show or have ideas about the show, please email me at jaferdcast@gmail.com. As with anything, don't take my word for it. Please talk with your own doctor, do your own research, because at the end of the day, I'm just another fucking ER doctor. Make good choices, everybody.